Any questions? Yes?
So thank you very much for the presentation. Actually, my question is for you, Dr. Levi, because you talked about not actually having aseptic loosening cases, that most of them are suspected septic loosenings. So I wanted to ask whether when you debride, you ask for cryosections and how many leukocytes you expect to see. And if a negative alpha-definicin in your aspirates prevents you from a washout, or if you go ahead and wash anyway.
No, it's a good question. And first of all, negative answer doesn't preclude infection. Alpha defensin negative, I said it. It's not positive. It's positive in about 50% of the cases. In P. acnes, I mean, maybe other bugs as well. You have to do a thorough washout. You have to, if you suspect it infected. I mean, for me, every aseptic loosening is septic until proven otherwise. And I take all the specimens, and the most of the times it will come back with positive. And I start the patients on antibiotics if I think that they are infected until I get the results back. So I think that most of the cases are infected. And even if you don't have loosening, if you have a painful shoulder that you can't explain in any other way, think about infection with P. acnes. You asked about the frozen section. There's no point of doing it because it's negative. And there was a paper from Cleveland Clinic showing that it doesn't work. And it's clear why it doesn't work, because the P. acnes does not cause leukocytosis. You can't find leukocytes, the five leukocytes per high power field. And this was one of the criticism of my paper for one of the microbiologists that read it. He said, oh, you couldn't show infection. I said, listen, I didn't look under the lamppost. I just describe what I've seen, and I've seen lymphocytosis. So if you look at it, the P. acnes behave a little bit like the Helicobacter. It causes lymphocytosis. It doesn't cause polymorphonuclease or leukocytosis, and that's why it doesn't preclude it. Yeah.
No, my question was actually about the very early infections or early suspected infections, because there you do not expect P. acne, but you might find polymorphonuclear leukocytes less than 10 per optical field. And that was a case like 10 years ago when I was working with Jörg Jerosch in Johann Etienne in Germany. He would actually specifically ask his pathologist to look for polymorphonuclear leukocytes on the frozen sections, without saying that it's
no, we don't do frozen sections, but we send fluid immediately, and we send at least 5 specimens, and we do a thorough washout. And if you do it early, you may save the prosthesis. And maybe you have to change the movable parts, but yeah.
I would like to ask Dr. Gamarello, thank you for being here. I have three short questions for you. First of all, what your opinion about sonication, if you feel that it's necessary now, sonication, when we remove implants, the first one. The second one, what is the minimal time you would consider stop the antibiotics? Dr. Levy said 2 weeks. This is the second question. And the third question is, how percentage of positive cultures, when we do a debridement and we remove the implant, you consider positive?
Well, starting from the last question, if you get more than 5 cultures, then you go up to 80% positive cultures. So it's very important to get at least 5 specimens, as you also raised in your talk. So that's the first. The second, always when we start treating the patient while waiting culture results, and after that we need at least 2 weeks IV therapy. And then we can continue orally, depending on the pathogen or if it is empirical. However, 4 months is I would say the last. People speak about 6 months, depending. The Infectious Disease Society of America, for instance, suggests 4 to 6 months therapy totally. And regarding sonication, I don't know if you have any experience. Do you use sonication in your reality? Well, we have it and we use it because we created the PhD thesis, and then we continued using it. It seems that particularly for Propionibacterium acnes, it's quite useful because you can get a lot of colonies, but also for our other fastidious microorganisms like the peculiar peak point Staph aureus colonies that could be created after prolonged therapy. So if you have it, do it. Otherwise, just proceed to the other procedures, and if you can't get it, that's okay.
Just 2 points that I, again, not to disagree, but we do it differently. We give antibiotics orally. We don't give IV.
From the early beginning?
From the early beginning, yeah. And because if the patient doesn't have any absorption problem, he will get antibiotics. There's no point of putting him in IV. And this is actually something unique, I think, that started with our microbiologist. That she's very brave and very ambitious. But I managed to persuade a lot of people around the world to do it. So there's no, but we give two dual drugs, as I mentioned.
You mean for Propioni or even for Staph aureus?
Even for Staph aureus. Even
goodness.
for Staph aureus, yeah, yeah. And
Okay.
so far, we are winning, so it's okay. And the other thing is about how long to, and that's a big question, because you don't know how long you have to
no
continue
studies
with
actually
antibiotics.
required.
So we empirically give 4 weeks. We repeat the bloods. I mean, if there is any change, we see the patient. If everything is quiet, there's no markers, everything is back to normal, and he's fine, and he feels fine, and all that, we may stop at 4 weeks. If not, we continue further. That's a big question when to stop. That's a major question.
Well, in our experience, whenever the patient just gets 4 weeks, then a lot of them, but I do not have the exact figures, they come back with relapses and resistance development. That's very important.
Well, that's a big question that we don't have the answer.
Exactly.
Yeah.
So we have to.
I follow the instructions of my feisty microbiologist.
We follow the Infectious Disease Society of America guidelines. Okay.
Offer, you said that you're checking the patient in 4 weeks, and then you decide if you're going to continue according to the lab. But pre-operatively, the patient had normal ESA. So what do you do?
I check the patient clinically. If there's no signs of infection, if he's quiet, if it's not painful, if he progress good, then I make the decision. But I don't make the decision myself. I always consult my microbiologist, and we decide together. And usually she asks me how is it clinically, and according to that, we make the decision.
Okay, let's suppose he is okay. Yeah. How long do you continue? Do you discontinue the antibody?
Sometimes I discontinue. Sometimes it's actually to do with what I started with. If I started with something which is possibly infection and it's not pure pus and all that, it's different. If I started with something which was a bath of pus, it's different. But you treat every patient a la carte, as I said. You tailor it to every patient. So sometimes we'll continue longer time. Some patients will continue for 3 months and the second stage or something. Yeah.
Do you use rifampicin in
Yeah.
reality? You do.
Yeah.
So we agree at least.
Yeah. No. Definitely, you need to use 2 drugs, rifampicin, and because otherwise they hide behind the biofilm. Yeah.
I've noticed that the dosage for the antibiotics was quite different in your presentations. So do you have a comment on this, or what are the recommendations about the dosage? The dose of the antibiotics, because in your presentation offer the dose was much lower than in the other one.
Well, if you are going to use penicillin, you need at least, if it's Propionibacterium or Cutibacterium, you need 20 millions, high dose. If it is vancomycin, it should be 1 gram twice daily, 2 hours infusion to skip Redman syndrome. If it is daptomycin, you need 10 milligrams per kilogram. It's a quite high dose. So you have to use the highest dose, because I think it's important to create better concentration in bone tissue, which is a disadvantageous tissue regarding concentration of antibiotics, plus the biomembrane, which is a great obstacle.
Well, I'm actually following the instructions of our microbiologist, But I have to say that I'm using antibiotics in the beads as well, so I don't need so high antibiotics level, because you have a highest level inside the joint and inside the soft tissues surrounding the joint with the beads.
Do you prepare your own beads?
I prepare my own beads.
Oh, okay, that's very important.
Yeah, but these are the dissolvable beads, and within 3 to 6 weeks, you can't find them. They're gone. Yeah.
What's your prophylaxis? What do you use for prophylaxis?
For primary shoulder,
Yeah.
we use teicoplanin and gentamicin. This is the protocol of the hospital.
So you do not use first or second generation cephalosporin?
No.
Very important.
Yeah. And for arthroscopy, if I do cuff repairs, I use clindamycin and gentamicin.
And you use just single dose?
Single dose, 1 dose, yeah.
3 minutes before?
Well, actually, not before incision. If I do, let's say, if I do the shoulder replacement, I actually take the specimens. When I have finished taking the specimens, I give the anesthetist gives the antibiotics, and this is the key to find this high level of P. acnes. Otherwise, you won't find them.
No, we speak about in general.
And I give it, and then when I give it, I give it about 20, 30 minutes before I put the implants in. So it's according to the American Society, it's fine. Yeah. Yes?
If you have already a patient inside the clinic, he's already on antibiotics orally, and you suspect an infection, you want to go for, again, debridement. You said 2 weeks you should stop. Is there any minimal time? I mean, 2 weeks is necessary for this, or there's some time less that you can consider and go for debridement?
2 weeks.
2 weeks.
If you want to grow something, 2 weeks, yeah.
Yes.
If there's no more questions, another one?
In the past, I have used these beads that you said, and I found out in most of the patients there was a fluid production, sterile fluid production, probably a reactive one, which was sometimes huge.
Yeah.
Do you see the same thing?
Yes. I mean, I've seen it occasionally. I've seen it in 1 or 2 patients. What you have to make sure that you don't put a lot of them subcutaneously. You have to put them in, because if you put them subcutaneously, they collect a lot of fluid. It's a clear fluid. It's sterile fluid, but it's frightening. Yeah.
Do you use defensin in your reality?
No.
Not interleukin 6?
No.
No.
I live in a poor country. We don't have the money.
I would like to ask Dr. Servasi, if you have ever done a single-stage revision or infection?
Yes. I did more than once, and this for early infections, never for the recurrent or the late infections. This because we have rules that are given by the university hospital, and we follow strictly their protocol. So one stage revision just in the early.
3 weeks, you mean? The first 3 weeks?
Please.
For the first 3 weeks?
Yeah, before the month, and after not, and we do not do the prophylaxis with antibiotics that could be useful for the treatment. So we do just a single shot of cephalosporin. Yeah.
Because it's very interesting for us.
Otherwise, they will kill you.
Sorry, just the last question. For the single stage, we know also from Germans that it depends also on the microorganism. Do you have a comment? I mean, there are some organisms that you can go for a single stage revision, some others that are more aggressive, and you have to go for the 2 stages. Do you have a comment related to the microorganism for the single stage?
If you know the microorganism, you can go for single stage. That's not a problem. If you don't know what the microorganism, but you suspect it's P. acnes, you can go for single stage. If you need to use bone graft, allograft, for reconstruction, you can't use a single stage, because you won't put an allograft on infected shoulder. So you need to do the 2-stage to make sure you eradicated the infection, and only then you can use allograft. But otherwise, my preference is to do a single stage every time I can do it, because there is, it depends on if I know the organism for sure. If I don't know the organism and I suspect P. acnes, yes. If it's, otherwise, that's most of the cases, and because the results, the clinical results, are by far better. And there's another study that I didn't mention from Mark Frankel as well, that they compared single and 2-stage, and the single were much better. So you have less damage to the soft tissues, so you get better results. So if you can do it in 1 stage, do it. And I think that these stimulant beads are very, very helpful to do that. Yeah.
May I say something?
Yeah.
This is a bit strange. I mean, do you think that the shoulder behave differently than all the other joints? Because
No.
the double staging procedure in all other joints are better than the single one from the point of view of reinfection. There is no doubt that in the literature, the single one in the shoulder
is
better.
Yeah.
So why is that? I mean, something.
I don't know. I don't have an explanation to that. I think the explanation on the function is because the shoulder relies more on soft tissues to good function. So if you do 2 stages, you damage the soft tissues. That's why the results are lower than in the hip or knee. That's my explanation. I don't know. But these are findings. I mean, I can't fight with them.
The infection again
is low. Is lower in the shoulder. I don't know. I have no explanation, but that's fact. Yeah. If there's no more questions, I think we can close this session, and I think there's some lunch or something.